Welcome back to my channel, Dr. Neurosurgery Greenberg. Today we are going to continue with the pituitary adenomas. And first of all, we need to know that pituitary adenomas are generally considered a benign condition, but you see, they can be invasive as well. And usually they can invade surrounding structures. And if you look at the non-functioning ones, they have a higher incidence of invasion. And even there are some tumors that are aggressive tumors and they are locally invasive. So, first of all, we look at the Wilson's or modified Hardy system to look at the anatomic classification of invasive pituitary tumors, what they can invade. So, first of all, we look at their suprasellar extension. 0 is none. A is expanding to the cistern. The suprasellar cistern has been breached. Then in B, there is the anterior recess of the third ventricle has been obliterated. And in part C, there is the floor of the third ventricle has been grossly displaced. That is the suprasellar extension. Now we come to the parasellar extension. In parasellar extension, there is D, which is intradural. It has breached inside the cranium. And E is into or beneath the cavernous sinus, which is extradural. So that is all about the extension. Now coming to the invasion. We have to look whether the floor of the sella is intact. If the sella is normal or focally expanded and tumor is less than 1 centimeter large, then it is 1. And if the sella is enlarged and the tumor is more than 10 in diameter, then it is considered 2. Sometimes there is extension into the sphenoid. In part 3, there is localized perforation of the cellar floor, and in part 4, there is diffuse destruction of the cellar floor. And 5 shows distant spread via the CSF or bloodborne. So we saw that pituitary tumors can invade the sella, the paracellar region. It can go down into through the floor of the sella and into the sphenoid and then out toward the body. And usually the pituitary tumor can invade the cavernous sinus, and the most definitive sign of cavernous sinus invasion is carotid artery encasement. And usually we call those tumors which are more than 4 centimeter in diameter and have a malignant course as invasive or aggressive carcinomas. So aggressive pituitary tumors are actually those pituitary tumors that do not respond to the standard therapy, and that is surgery, conventional medical treatment, radiotherapy. They're not going to respond to any of that, and they will present with multiple local recurrences. And actually, they are not recognized in the new CNS WHO 2021 classification. Then there is another entity called pituitary carcinoma. And pituitary carcinoma actually is a pituitary carcinoma which is spreading systemically through the CSF. And in these tumors, we see that the Ki67 or MIB1 index is high. Ki67 more than 3% and positive p53 expression and a mitotic rate which is more than 2 every 10 high power fields, that is considered a pituitary carcinoma. So that is the criteria. And in these patients, what we can do is that we have to do the routine pituitary tumor screening, the hormones, the visual field, and you can do the screening for metastatic disease as well. And then the pituitary surgery, after the pituitary surgery is done, you will do the biopsy. And in the histopathology, the Ki67 is more than 3, P53 is positive, and mitotic rate is more than 2 per 10 high power field. Then that means that you have to consider a repeat surgery if there is recurrence, and you can also go for radiotherapy. And the radiotherapy regimen is the same as the STUP regimen we will discuss for gliomas. And in the STUP regimen, you give temozolomide, and you give approximately 150 to 200 milligrams per square meters of temozolomide with radiotherapy, and you give it for 5 consecutive days for every 28 days, and you do 3 cycles of this, and then you check the patient. If there is a response, then you continue this for 6 months. And if that doesn't work, then you can use other chemotherapeutic agents. And if there is metastasis, then you have to locate that metastasis, and that has to be consulted with the tumor board. And then you have to repeat the MRIs every 3 to 12 months to keep a check on it. So that is all about pituitary adenomas today. We will come back in the next video about the clinical considerations of the pituitary adenomas. Until then, God bless and thank you.